Dear colleagues, it's a great pleasure and honor for me to introduce and welcome Professor Feifan Ouyang from the UKE Universitätsklinikum Hamburg-Eppendorf. Actually, Feifan is a name which needs no introduction for those of us who work in the field of electrophysiology. Everybody all around the world who is working in EP knows Feifan because of his pioneer contributions in the field of electrophysiology. Feifan did so much to improve our understanding of various complex arrhythmias, atrial arrhythmias, atrial fibrillation, ventricular tachycardia, ventricular arrhythmias coming from the aortic root, etc., etc. Feifan worked more than 2 decades in Hamburg St. Georg Hospital, Asklepios Klinik. Am I correct?
Yeah.
And after, I think, 24 years, he moved to the other clinic, the bigger clinic in Hamburg, the UKE. And since then has been working there along with his part-time work in China, in Wuhan, China. Well, I don't want to speak more, and I give the podium to Feifan. And we are very excited to hear what you tell us about the history of cardiac electrophysiology.
Okay, dear Chairman. First, I would like to thank Professor Notitzky and Professor Duna and the Professor from Korea and from. So I made first I would say it's my pleasure here. But I made Korea as in 1997 at Hamburg. So we did the first 3-dimensional map system. And as you remember since 1997 as the summertime. So and first and always I thank my friend and my old fellow, like Arden Zagula, give me a chance and invite me to here. We did some cases here and give me a title talk about catheter ablation of arrhythmias, or the history and or the future prospect. The ablation history is very, very short. It's not like different with heart failure. So we are the arrhythmia part as ablation. The first we start 1981. Okay, the first ablation was by control the drug. The patient had atrial fibrillation. Did San Francisco by Mavis Sharma and Fred Morady, which was published in JAMA as 1981. And later, the people report for 5 cases with so-called supraventricular tachycardia or the atrial fibrillation with a fast heart rate and the refractory drug or drug treatment. So he put a catheter ablation. They call it his at his area is DC show, and the result total AV blow to control fast heart rate. This is first the report 1981, and later we did all the pioneer like from Hare Venus group and from Mark Fairdaffy group and from US some group, and did a knowledge-based research to identify how to differentiate diagnosis was the AV tachycardia or is the AV tachycardia used accessory pathway to conduct. And then as the milestone papers was found by the Dutch, the pathological and the Baker. So he used the 7 patients had so WKW had sudden cardiac death. Okay, and the pathologic finding is a pathway is normal myocardial. Is close to A and V, so-called AV channel part. Is called the fibrosis tissue. So the pathway have atrial insertion, had a ventricular insertion. Is a small fiber. It's a myocardial fiber, and as we have atrial insertion, have ventricular insertion. Normally as a 6 to 10 millimeter. This provide the most important one for later for San Jacob and for Hans Cook to find the possible potential. So if pathway is myocardial, the must be have conducting, have exciting, and can record the normal, the atrial, or the eventual, the potential. This was the initial for Sandy Jackman is over the one for me. I think he's one of the best, the electrophysiology one. So he used the catheter, the octuple catheter, for the coronal sinus, just a perpendicular to angles to record. So use a different pace and the atrial pace and the ventricular pace different. If the potential is not atrial, it's not it must be ventricle or pulse potential. So he used the second one, pace ventricle. If the potential is not atrial or not ventricle potential, must be it's so-called the pulse potential. So he used the spatial catheter and used the spatial pace technique to record the pulse potential. So this was the milestone for catheter ablation. This is published in 1991 in the New England Journal, 3 papers in 1991. As the first one, Sandy Jackman. The second one was Hugh Calkins, was the mentor of our friend Philip Duran, the mentor for published the New England Journal one. And the third paper, as from Hans Cook, was sent published Lancet. The story was initially was sent a paper as if I understood this, the initial as Hugh Calkins sent a paper to New England Journal, the first. Hans Cook sent the second one, and the paper was rejected. Okay, and the New England Journal called Sandy Jackman. He said, well, 2 papers is submitted to the New England Journal. Because in this, everyone knows Sandy Jackman did multiple cases and was successful. So that's the reason 2 papers published in New England Journal and the Hans Cook published nonsense. So all the cases is mostly WPW, and a few cases, like 30% cases, is every node tachycardia, and so the successful are more than 95%. The first one. The important one is to use the one like Sandy say, okay, if you can't use target, if you find a spatial potential, like so excessive pulse potential, the ablation number is about days. The successful was high. So this is what that before 1995, every people daily use the stuff. And this is what the column we use for the ablation SVT. So we use 3-dimensional map system. We put a body catheter in the atrial part, and they use the native frequency, identify which was the appropriate target, and use for every blow. The second was more in the papers from Sandy Jackman. So he did every node tachycardia. But before 1991, always debate is every node tachycardia is atrial involved, it's not atrial involved. So Sandy first used so-called slow pulse potential. So locating the right atrial until CSOs. So, and we call it so-called slow pulse potential. He first used atrial insertion involve the every node tachycardia. So, and they did ablation and make most successful. So this was initial Sandy Jackman probably okay, use native frequency ablation in the anterior, the right side, anti-inferior, the part, the successful part. And the more important one, so he correlated for Andrew Baker found that the so-called every node tachycardia. We like before 1991, we use every node tachycardia, so-called localization inside every node. And the Sandy circle is so possible, and the Damon so possible participate in the circle. And further, like 6 years later, Andrew Baker did the pathology found. He found that most patients had right posterior extension, 30% the patient have left posterior extension, and face the pathological, the pathological anatomy subset for the every node tachycardia. So this data what we use. So every node tachycardia, we have every node, we have posterior extension, we have left posterior extension, we have right posterior extension, and the correlation with the subset area. And later we move to the so-called focal tachycardia. This is always simple, the subset. So simple subset. So most of the focal tachycardia, the localization distribution from Australia, the camera, he was a fellow for San Francisco. He did a lot of studies about the ECG criteria and local right side and left side, most right side located crease terminus and close the tragus areas, and left side most macro areas and close the pulmonary vein, the also area. Inside right atrial left atrial is very, very rare. So in most, we have 10% tachycardia located close the corpus triangle area. So no, it's average here, some high risk for AV blow. So we did first, we found, so the atrial tachycardia can be ablated from the aorta, non-coracospid. This we published in the JACC 2006. So we found no myocardial inside non-coracospid, but we found a small myocardial AV cardiac fiber close to non-coracospid that with a very, very short anatomy distance. This approach we use for daily use for ablation for focal tachycardia for close palliation the tachycardia area. So this, and we try to avoid potentially the complication the area. So the third one we use for the background tachycardia for the atypical, the background tachycardia is the atrial flutter. So atrial flutter typically along the tragus areas. So use a clockwise or counterclockwise and along the tragus areas, just make it like surface ECG as is a range tachycardia. Before 1995, we always use, let's say, termination, the flutter, and use endpoint for cath ablation, but the recurrence about 25 to 30%. So, and from 1995, and the initial one, from the French, Poti, and the Saudi, did a very excellent study. So he put a catheter inside not located right edge free wall and use the different criteria, just conduct block, the cable tragus isthmus, and can reduce significantly reduce the recurrence. So compare the before use of termination, non-reducibility, and the use pattern block, the criteria can significantly reduce the recurrence for atrial flutter. To be honest, the major for the electrophysiology, the most important for help us is a genius guy, is Shlomo Ben-Han. So he was introduced a so-called three-dimensional map system, and from 1997, he's a Jewish. He was our friend, so he founded a company for the bioscience, like in Easter, 1993, and he found first paper of Nature Medicine. It's a three-dimensional map system recording electroanatomy and electrophysiology signal, the part. Use this one, and later we developing use a notified tachycardia for marker-like tachycardia for atrial fibrillation. So the more simple, just the figure of A after surgical procedure like ASD, VSD, after like say complex surgical procedure for the scar-related atrial tachycardia, you can see and like the activation map, and you can use the propagation, see the activation waveform, and you can see use a voltage map. Just voltage map is subset. The normal tissue, you can find where's the surgical cut, where's the surgical suture, and where's the pathological, the fibrous tissue area. So help us to increase the successful area. The most important paper in this study is Nakagawa and San Giacomo, and he published first series record use three-dimensional area to treat so scar or incisional range tachycardia. Finally, both have the old patient have two scar. Between two scar has small channel. You can use focal ablation can cure the old atrial tachycardia, the part. And we use the same one, and we can use for left atrial. So then we report. We took report. One is from Hamburg, one from the Bordeaux. The both report as after 1-2 years. We use this machine, this mapping system for left atrial the tachycardia. Before as 2000 extreme layered paper the public code for left atrial tiger. This we did the initial part. And you can find the left atrial tiger, same one, and you can find the skull area, and you can find the so-called activation map along the tragus iris, and with a dense skull located anterior, and you can use all the electrophysiology endpoint and confirm its tachycardia and do the focal ablation and make tachycardia termination one. As from 1997, as we moved more further to atrial fibrillation, because atrial fibrillation is dominant and is most common arrhythmias, and we did most study used ones from Michel Haskell from Bordeaux. He found the patient in the very early one, the frequent short episode, paroxysmal atrial fibrillation, and during the procedure, he found the original, the initial start is driven by the faster the tachycardia. The most location is inside the pulmonary vein, more frequent the left superior vein, right superior vein, and left inferior vein. Some case located right side and located septal inferior vein. This is like surface G. You see that they put one catheter inside the pulmonary vein. It's a sinus and the two sinus speed and XBs, and induce with a trend fast atrial activity, induce the atrial fibrillations. This approach just use us, okay, if we can elimination the earlier PVC, the atrial extra one, can treat atrial fibrillations. So initially we use the ablation the focal side, and we concentrate high, and later we use to put the catheter inside PV and use so-called segmental and just a breakthrough of PV to short as the inside walls and to cure atrial fibrillation. The shortcome of the exon, but long-term come is most of very high recurrence. Potentially can induce needing the PV stenosis. So based on the finding, so we start atrial fibrillations, like say do the power based on 3-dimensional maps to try to find the base vein to isolate pulmonary vein. So as this is Carlo Papola from Milano. This myself is 1992. From 1997 we start atrial fibrillation. So we did the same one, use a 3-dimensional map system. So we put this is a PA view. This is a left superior vein, the left inferior vein, the right superior vein, not inferior vein. So this is from Milano approach, and we put all along all to ablation. So based on this experience and over previous experience, we know if we burn deep, potentially the kidney outcome is less successful and potentially can put a complication. So we first use, so we call so double lasso technique. We put a so-called linear lesion along ipsum the pulmonary vein. We put one catheter like right superior vein, one catheter the ipsum inferior vein, and we did 3 sheaths in the left atrial. We tried ablation along the pulmonary vein, ipsum pulmonary vein. We tried observation, the PV disappear, yes and no, and the activation pattern is same time, no same time. So we found that the interest finding here, you see in the most cases, if you make the lesions is from the opposite O's, even for right side vein or left side vein, you see we put one large catheter in left superior vein, one large catheter, they call it the inferior vein. You found the both PV, you can simultaneous isolation. This is the approach, just that you can demonstrate with the both pulmonary vein can be isolation from left atrial the first time we report. And it's more important one, and this one was finally demonstrated reproduced by all lab and used for daily for so-called use guideline for this approach for the ISO PV isolations. Okay, for all the ESA guideline or the HRS guideline or the HR Pacific, the guideline here. So more importantly, like we follow the old patient. The first time we did 5 years follow-up. we found old patients, the normal heart, the young patient, almost left ventricular function almost normal. Or this patient have 7% have hypertension, less comorbidity. During 5 years follow-up, if you do the PV isolation, so major of the patients, you see 80% patient is still sad rhythms. It's without any medication of 80%. But single procedure, just say the 45%. The problem is due to the recurrence, the lesion formation, the lesion formation and less energy. If new technology coming can solve the problem. So more important, the clinic one we know atrial fibrillation and heart failure is a big problem for clinical practice. So if you have atrial fibrillation, you have increased heart failure. If heart failure, you can increase the incidence of atrial fibrillation, which patient will get benefit for most the persistent AFib patients. So we know a lot of patients, like say, if you the clinic come here, the patient with heart failure, you see the atrial fibrillation with fast frequency. And after PV aspiration, the patient is EF and non-patient EF significantly improved. This is a study from common study from the Australian group. He used cardio MR. So from the patient who can persist AFib, is not identified which reason induced atrial fibrillation. Most patients had fast heart rate. So he did PV aspiration and the box lesion. He found most patients old left ventricle EF significantly increased. So more important one, every patient did a cardio MR before the ablation. If he found no clear the negative cardio MR, the patient EF they covered to normal. If patient had so-called fibrosis on the left ventricle or septal or inferior lateral, the EF improved much less. So most he demonstrated in patient had unidentified reason for heart failure with fast frequency, fast with atrial fibrillation and fast heart rate. If cardiac MI is negative one, most likely is due to the atrial fibrillation induced the cardiac absence. So later we know the ablation by point ablation based on the 3-dimensional ablation system. You need a very long, short the learning curve. Is a very complex procedure, and this challenge make the lesion to transmural means from endocardial to epicardial, and the potential make complications. So we have used, because atrial fibrillation is big clinical burden for daily practice. We need a simple and the fast and more safe, same effective the procedure. This is what the crab balloon become. So we did the 5 hours studies. So we take 10 years of published the New England Journal as 2017. We compare use PVI use based on the 3-dimensional map system or the radiofrequency ablation, and all the other group use a single shot device for the crab balloon the technology. The study demonstrated the burst was equal effective in patients had paroxysmal atrial fibrillation. This provides the daily use for atrial fibrillations. So atrial fibrillation, when to treatment, if it's early treatment is benefited. So this is the ESA study, the Procedural did the ESA study, in including the high-risk patient. So the patient had more than 70, or has stroke, or the TIA, or has more than 65, had multiple comorbidity. So one group just early rhythm control, just the AFib, less than 1 year, and if other group just use later control to compare the composite endpoint, mortality, stroke, and breathing. They found the early rhythm control can reduce, like mortality or stroke, bleeding, or heart failure, or the acute cold artery syndrome patients. This the ESA studies. This is why we daily put the Hamburg with the most sick patient. We do a lot of ablation part. Is this the ESA studies? So we know that the ablation, the atrial fibrillation, we know the paroxysmal atrial fibrillation is excellent overcome after 5 years and even 10 years. And we did 20 years follow-up, the patient had excellent outcome. But however, in patient have persistent atrial fibrillation, or especially in patient have long-standing persistent atrial fibrillation, the catheter ablation, PVR plus, the outcome is much less. The patient have a persistent atrial fibrillation, require more cardioversion, okay, and maybe have more increase the stroke, the risk. So how do we treat the patient with a persistent atrial fibrillation? So we know every lab have different, use coffee, okay, linear lesion, GP ablation, complex termination, the stabilized approach. But the multiple center data all very difficult they produce. So we did a study. If it's possible, we do early ablation can stop or prevent or delay the atrial fibrillation the process. So we did a test trial. We added together with Hans Cook as from 2009. So we published 2020. So we one group with in patient had a paroxysmal atrial fibrillation. So we use a heart score, the heart score point. The patient has more chance to have heart failure, have hypertension, cardiomyopathy, or definitely hypertrophy one. So with one group we do ablation. With one group we do the basic the medical treatment. So the anti-arrhythmic drug treatment. We follow up the patient for 3 years. The clinical endpoint just how many percent of patients developed persistent atrial fibrillation. The data clearly show the catheter ablation. You see that after 1 year, 2 years, 3 years, the incidence of atrial fibrillation of 1%, 2%, or less than 3%. In patients had medical treatment atrial fibrillation, they every year 6%. After one follow-up, the first year 6% developing persistent atrial fibrillation. The 2 years about 12%, and the 3 years about 18% developing persistent atrial fibrillation. This study demonstrated, okay, can only ablation can delay or the atrial fibrillation progression to the persistent atrial fibrillations. So we need, if the atrial, we probably in the future, but we need the simple, faster procedure, like say, follow past the different energy one. This we come use like your center, you use the so PFA, follow past ablation, can make fast one and easier the procedure. This data manifest trial can demonstrate if we use PFA, can make even expert center, like say more, he divided 3 centers. One center did more than 100 ablation, one center much less ablation, one center in the middle found different, no difference. Okay, so this way can prove that this method and this technique and new energy can common use even for smaller the hospital, the reasons. The second one is okay, the ventricular arrhythmia part. So first, as from 1991, we did most like simple substance, like focal arrhythmias, like typical overtract arrhythmias. So you can add mapping, you can do activation mapping. If single focal ablation here, and you can eliminate the ventricular arrhythmias. The issues here, they all how to differentiate the arrhythmia for right and for left side. The next we found, okay, the first we demonstrate here, we found the ventricular arrhythmias can originally can be successful in the aortic casket, especially the left side, right side, extreme rare in the non-collateral area. This we initially report. So the spatial, so-called antipassive ventricular arrhythmia, they call it from left front, successful ablation from aortic sense catheter. In this patient, so we found a spatial one based on anatomy part. So anatomy aorta located in the center of the heart, off tract, right ventricle off tract located in the anterior more left side, produce a vector on the chest V1, V2. So we use the initial, we use V1, V2, count the criteria on the surface G, the V1, V2, the R wave, the duration, the R wave amplitude during PVC or during the VT can suggest maybe the ventricular arrhythmia is from left side. This is the first we report. And also we provide use pathologic data with cooperation with from London, Noe Brompton, the hospital, the very famous professor, the Yan Ho. And we found the muscle located in the sinus and they close the bottom of sinus, the aortic sinus, especially left side and right side, the part of myocardium. This provides anatomy substrate for antipassive for ventricular arrhythmias, the area. So in the ventricular arrhythmia part, so we have some spatial part we can locate above aortic valve, can be located below the aortic valve. In the left ventricle below the aortic valve, spatial left ventricle, some area, spatial here. So we can develop the new approach, use a transcept approach and to ablate below the left ventricle, below left choral sinus part or the radical part, use a transcept approach and can be ablate left ventricle some area. This example is a PVC. This is a trigeminus and is two sinus bead. We have space component here located between the RCC and the ANCC, the junction part, sync application can terminate all arrhythmia part. Also, we found some spatial arrhythmias, like say antipassive ventricular tachycardia, without with sensitivity at tachycardia. We found spatial, the potential located the left ventricle posterior percutaneous network. You see the sharp, high frequency, delayed component. So we hypothesis the without pump sensitivity activity is a migrant tachycardia, is have two percutaneous fibers, one's antegrade, one's retrograde. It was demonstrated by recent old study. This was long ago. The more complicated arrhythmias is due to scar-related VT. So as indeed, this made a major contribution for B.S. Stevenson. So he did 1997, used old entramped maneuver based on the VT circle. It's a three-dimensional map, and he used imagine, just use computer model. His circle suggests the VT pole has the exit, the entrance, has a slow contact area, has outside loop. He used entramped material to identify the VT circle. So based on this one and the most important one, the two studies, so the subset the study. The two groups make major contribution for the VT ablation. The first one, so from Philadelphia group, Marcininsky leading the group. The second one is from Boston, the group, the B.S. Stevenson. Colina was part in the game. She was she did a major contribution in the subset identify the VT, okay, from subset, from locating the myocardium, the border zone, use pacer and maneuver can find okay, the subset and improve the successful. Like we daily doing so the VT subset map. So we can induce the VT and if we found the subset area here, use a voltage map. We found the normal voltage more than 1.5. We found no pace, no area, and use so-called abnormal area. We use pace maneuver, identify the VT, the exit, and potentially can find the so-called the entrance, the way, and you can terminate the VT, the area. So ablation VT use so-called substance modification can reduce the multiple shock, can reduce ATP, can reduce so-called amiodarone, the use, and reduce so-called hospitalization due to VT or heart failure. This was demonstrated by the so-called Circulation, the trial, the studies. Most clinical, most used for the clinical trial, just as a body trial, published in New England Journal. So VT ablation compare antiarrhythmic drugs. So most benefit, the sequence. If sex more longer, more benefit. If patient had electric storm, it's much more benefit. And also benefit location, the substance location. If the substance location is inferior, there's a benefit. If substance non-inferior substance is much more better overcome. The problem is due to in patient had inferior myocardial function patient had more substance locating subepicardial myocardial area. So in the non-ischemia cardiomyopathy patient, most of the contribution is from the field, is from Philadelphia, from Los Angeles, from the Holland, the Zeppelin group, and the device use cardio MR and they use so substance map to different and the substance location and use more imaging to identify and improve the overall successful. So you know the ablation for the non-ischemia, the cardiomyopathy, you see here the patient had genetic mutation one compared no genetic mutation one. If had genetic mutation, the kidney overcome much more less. So more important one here, we knew the kidney overcome. We know in stroke heart disease patients have some space group to so-called ARVC. So ARVC, our friends, okay, Finland and Colorado and the University of Zurich did a major contribution for identifying which patient have risk, which patient have pathological, and very, very notable basic research for the ARVC group. So we know the ARVC is epicardial, it's more bigger, the substrate, it's much bigger than endocardial, normally 3 times the endocardial. But we did the over approach. Zagula was published a paper with JACC a few years ago to compare one group average endocardial, one group called endo and epicardial ablation. He found not too much significant difference compared endo epicardial ablation. The number one is probably is here these patients, okay, and it's due epicardial fat. Number two, this patient, most young patients. If young patient did epicardial ablation, after ablation, probably they may be due to adhesions or they due to after ablation one. This is why we make recommendation to sequential ablation, first to endocardial ablation. If endocardial fail, we do epicardial ablation. This data was common use in the older lab, the data. This was Zagula and Shibu was published in JACC. Right. Thank you. And recently, most people focus for ventricular fibrillations. The most did contribution is from Bordeaux group and Lara body group. The most important finding in patients with, like say, in Brugada patient, we found epicardial right ventricle anterior found small substrate. We use epicardial ablation. We can normalize the Brugada ECG, and you see if ECG is normalized, the ECG, the patient has excellent the outcome, can almost no show during follow-up of 10 years. in patient had the residue, the ECG pattern of Brugada, the acid number significantly reduced, but they can still accuse. So this was the hypothesis. The reason is the hypothesis. So Brugada, the patient, the early stage, maybe it's called concede, maybe present epicardial fibrosis part, and the later stage became circular overload and myocardial cardiomyopathy. So finally, we address, we ablation use from the 2-dimensional ablation, we use 3-dimensional ablation. The more important successful, we have help us to understanding the radio frequency induced the lesion for biophysics. This one was most the contribution Nakagawa and Sanjigma, the animal, the model. Use law and use which was temporal control and measure the lesion formation and distance to help us to understand not only say how to make the proper lesion to treat the patient and reduce the complication and the branches of the impedance and the local impedance and the temperature one and the pole and improve the clinical outcome. So, ladies and gentlemen, I will make more conclusion. The catheter ablation is for arrhythmia. Is if the arrhythmia history is the initial of diagnosis to catheter ablation. The ablation initial from simple substrate such as pathway, avial tachycardia, focal tachycardia, or focal, like say, overtract arrhythmia, and to the complex arrhythmias, like such as recurrent tachycardia, like ischemic VT, and the ventricular fibrillation, atrial fibrillations, the part. And later, able to move the arrhythmia ablation part from the phenomenon to evidence-based medicine, the clinical trial, to try to understand the disease progression and understand the progression of disease. Okay, and this one, the most important, the 3-dimensional medicine played very, very important role for help us to understand the mechanism and understand the so-called, the improve, the successful. Thank you for your attention.
Thank you very much, Feifan, for this excellent summary of the history of catheter ablation and the overview of various arrhythmias. I remember in earlier days we were doing basically only WPW ablation or AVNRTs. They were the most prominent, most common arrhythmias. Over the years, the landscape is changing, but these arrhythmias were also are very elegant arrhythmias. We just give one burn and we cure these patients with WPW syndrome for lifetime. But over the years, we moved from point elegant ablation to more linear ablations and more surface ablations. We kind of eliminate large areas of atrial or ventricular substrate, kind of like a paradox, right? We are ablating more and more, and even the new tools like the pulse field ablation, it's like surface carpet bombing, right?
Yes.
We ablate more and more. So this kind of seems to be the new trend in electrophysiology. What do you think?
Yes, this absolutely excellent one. You know, the clinical one we face as we did the training. Like suppose the very beginning with a simple substrate. The very beginning we do WPW, we spend 5-6 hours to identify or to diagnosis with possible location, how to identify the pulse potential, how to use the old pace maneuver, and try to single ablation to eliminate the substance. Today we move the most clinical jobs atrial fibrillations. Atrial fibrillations, most every center to PV isolation. PV isolation, either you need circumferential or the polybipolar ablation or single shot device, as you mentioned. Single shot device, we have servo, the lesion, use crab balloon, laser balloon, the hot balloon. And these are new energy, so-called PFA. So far apart to pass field ablation technique. So it's a totally different energy. The concept as the same. We not make great revolution, but the energy make fast, simple. The learning is a learning curve.
Many colleagues are listening us online. So what is your, as a very experienced senior electrophysiologist, what's your advice to younger colleagues who want to step into the field of electrophysiology?
I think for the young people, the generation have to first have to manage clinical job, because clinical face, like the Hamburg, China, as the problem like the Schweiz is same one, 80% atrial fibrillation. You have deal 80% of the patient because you have too much patient waiting for ablation. So recent data, the early ablations, like this trial, early treatment maybe can reduce the endpoint. So this is most young people to face a problem, okay, daily clinical practice. For the complex cases, I think the people have to understand the basic, the electrophysiology, how to differentiate diagnosis, how to differentiate which was possible, atrial tachycardia, or finally avalon tachycardia. So 1 week, 2 weeks ago, I made one colleague. So the guy is a very expert physician. So he misdiagnosed a very funny possible. So he misfound the diagnosis. So we have to do teaching people because we are dating the young people like Mahan, atrial fascicular, not a bunch of fibers is rare disease. So maybe the 1 year we never see the cases. So we have to teach the young people how to understand, how to use the 3-dimensional map under the basic mechanism, how to different diagnose which was arrhythmias, how to mapping the finely layered arrhythmias.
So much. Are there any questions from here or from online?
Yes, maybe ask. I wrote them. So
you wrote
I have no question yet.
You don't have any questions?
But they should unmute if they have a question.
So let me ask something else. The field of heart failure and atrial fibrillation, ablation, and now there is some more evidence suggesting we should need to ablate more and more in patients with heart failure, more advanced heart failure. What's your opinion on that? So which patients with more advanced stages of heart failure are good candidates for atrial fibrillation ablation?
Yes, excellent question. We know we have 3 excellent the trial, the CardioZurich trial, reduce mortality. With Hamburg trial, we also know the ablation is no benefit. The CardioZurich trial, every patient get a benefit. So we have means we have choose the patients, which patient most benefit. I'm sure another patient benefit, but at the end of stages, maybe no benefit. Recently, I have one paper published in New England Journal. Just say use ablation PVR can make a bridge to the heart transportation to maybe change the left ventricular function. And so we need urgent data, which patient more benefit, and which is maybe called MR, maybe biomarker, and which ones left ventricle was reversible as probably more benefit. Yeah.
There is one question from online. What do you think? Where is the future of the electrophysiology and where does it go?
The future of electrophysiology and where does it go?
Okay, for research, it's, to be honest, it's more difficult. Like we are and the phenomena we did the last 20 or 30 years, we found some use of phenomena, found single cases, and also you finally use all the cases to demonstrate the mechanism of tachycardia. To be honest, it's very, very difficult to find some new risk the mechanism. But you can do cooperation with different diseases. So we most face some more complex diseases like atrial fibrillation, ventricular tachycardia, ventricular fibrillation, and like atrial fibrillation is multiple, is factor influence diseases. You have to more cooperation with multiple departments, like say imaging, okay, and diabetes metabolism to the department, and just comorbidity one, try to use do clinical trial or do very basic research to understand why I have atrial fibrillation. Like I and Fina, we both have left atrial, we both have problem when. Why we have no atrial fibrillation, why some age, same age, had atrial fibrillation. We have to understand, do more basic research, find a different the mechanism for the atrial fibrillation for the ventricular tachycardia.
A provocative question. Do you think there is a chance that there will be a wonder drug, a new antiarrhythmic that will solve all atrial and ventricular arrhythmias, that you and I will be jobless, and as well as all other EP colleagues? Where is the medical therapy heading to? Is there any light at the end of the tunnel or no?
I think so far, if I understood, so far, as I don't think so, less than 10 years, we need a basic scientists to make some breakthrough to understand the mechanism. If we found the spatial atrial fibrillation, ventricular tachycardia, or ventricular fibrillation, we found a spatial mechanism. We identify the single and like the mechanism. I'm sure the drug can change the games. So far, looks atrial fibrillation, ventricular tachycardia is a progression disease, and they probably need to work together more for all the department, for other department.
So until
yeah.
Okay, there's another question from online. What do you prefer for the treatment of a classical old-fashioned WPW 3D mapping or normal 2D EGM tracing with fluoroscopy?
Okay.
Question: do we need 3D mapping for WPW or not? Or do we do it the old way, conventional?
Number one, like I and the Fina, we both the training WPW, we never use the very beginning, we don't use 3D mapping system. We try the single application to kill the pathway. So the 3-dimensional map has 3 advantages. Can base the one to identify, mark, alarm location, can reduce the fluorons, like extra doses, the doses for patient and for physician, especially the kids. Like for the young people, have no daily training for practice for the WPW. So probably 3-dimensional map can most easy for identify, mark, alarm location. But for the average for WPW or simple subject, you need a very, very basic knowledge how to differentiate where's the pathway. Like say, the left side pathway, right side pathway, is positive pathway, is positive pathway, right side, left side, associated myocardium. You have used all the ECG criteria, you have used all the basic, the EP knowledge to differentiate, to diagnosis. I think it's more important for young people understand the basic mechanism, and the young people understand another 3-dimensional map very well. You have to understand basic epidemiology, especially if I have understand the lesion formation, what it means, how to produce the proper lesions, that for the young people, probably most important. For me, the electrophysiology on 3 parts. Anatomy, EGM, just you have to understand the electrogram, which was far field, which was near field, and the potentials, the critical, it's not critical. And if under mechanism, you know the location and how to make the proper lesion. This is more important.
There's another
Another question, your final one, because we're then on time.
Will PFA change the field so that we do not have RF and cryo anymore in a couple of years?
So the question is pulse field ablation the ultimate solution that we don't need to burn or freeze?
I don't know. So we listened only 2 trials for PVR. The one is so-called like case cohort studies, like say from Frankfurt, compare 200 cases, use PFA, 200 cases with cryo balloon, and the result, complication, not much difference, number one. Number two, the randomization trial by Vivek Lady published in journal, almost 720 patients. One group's randomization, one is PFA, one use temperature condition, either is point by point ablation, use a cryo balloon. But the data show it's no difference, clinical outcome and the complication one. So if I say, if I would ask after ablation, probably I will use the more positive one, maybe the PFA, the anterior one, maybe I use the physician. If I knew Finland, I will ask the physician maybe do the PF, the native frequency for me. If I don't know the physician, I will ask the guy to single shot device. Either use the PFA, use the cryo balloon.
Well, thank you very much. We are perfectly on time. So until there is a wonder drug or so, we'll probably have lots and lots of ablation in the next 10, 20, 30 years. So we can recommend our younger colleagues to go into the field of interventional electrophysiology. And with that, we thank you so much for your excellent talk and for accepting our invitation. And I also thank you very much that you come and, in the last couple of years, you come and support us in very complex ablation procedures and epicardial procedures. We really appreciate that. And so that our patients benefit from your expertise as well. Thank you so much, and hope to see you again. And
okay.
Go to the cath lab.
Yeah. Thank you. Okay. So, thank you. Yeah. Thank you. Okay.